We're going to talk about termination of resuscitation and not starting resuscitation on a certain subset of patients today. If you're familiar with your Alabama EMS guidelines and protocols, you know that one of our guidelines, 18.03 to be exact, the death in the field guideline, refers to a certain subset of patients that we would not consider really starting resuscitative efforts on. One of those is obvious decapitation, massive crush injuries, evisceration of the lungs, heart, etc. Incineration or patients burned beyond recognition, rigor mortis in a warm environment, decomposition of the body, obviously a DNAR patient, and then a pulseless apneic patient in a mass casualty situation in which the number of patients have overwhelmed the resources that are present at that point in time. Again, if there's ever a question, again, our fallback is to contact online medical direction and get direction and orders from them to determine whether you want to work these patients. Now, if some of you have been coming to the SMIC meetings, you know that there's been a push not to call medical control on some of these patients. If you refer to the guideline, you know, we have always said that if you're not going to start resuscitative efforts on a patient, you really need to call med control and run it by them. There's some push on obvious death in the field, decomposition, incineration, etc., not to call medical control. Again, that's not in place yet. That's something that we're looking at, that you may see at some point in time, but certainly not in place at this point in time. So my advice to you is to follow the guidelines and call medical control if you're not going to start resuscitative efforts in the field. What about traumatic cardiac arrest? And blunt trauma patients usually don't survive beyond transport and survive a blunt traumatic cardiac arrest. So if you find somebody that's a blunt cardiac arrest in the field, I'm not saying that they can't survive, but many times, and probably most times, a blunt trauma that's pulseless apneic in the field are not going to survive ultimately. So, you know, you need to start thinking about calling medical control and not trying to resuscitate a blunt trauma arrest. Some people even talk about that if it's a blunt traumatic arrest, obvious death, that you really don't even need to put them on a monitor to determine if they're dead. Obviously, you know, and if there's a question, obviously you can put them on a monitor. And then one thing I will say that many people will tell you that if you have an organized QRS complex 80 or greater in a blunt trauma patient, then you may want to consider starting resuscitative efforts, because those patients may can survive. But as a general rule, blunt trauma patients that are obviously pulseless and apneic when you arrive on the scene are probably not going to ultimately survive. What about penetrating injury? Well, penetrating torso injuries are somewhat different. Many times penetrating torso injuries may have a potential for surviving their traumatic event. So if it's a penetrating torso injury, contact medical control immediately, get advice from them, because you very well may want to start resuscitative efforts on those patients. Another issue that comes out through our protocol and our guidelines is that if a physician on medical control stops resuscitative efforts or tells you, you know, basically to stop resuscitative efforts either en route or on the scene, and you're going to still have to transport the body. And I know that's probably not something that we routinely do, but sometimes in rural areas they do. But as a general rule, if you're stopping resuscitative efforts after starting resuscitative efforts, you need to take that patient to the physician that gave you orders to stop those resuscitative efforts. Again, I understand that many times that's impossible. You're talking to medical control that may be 60 or 70 miles away, and you've got a local hospital that you need to take that patient to. And I understand that. If that is the case, then you really need to contact that receiving hospital immediately and let them know that your medical control is giving you orders to terminate resuscitation. So, what about termination of resuscitation once you've started resuscitation? Most out-of-hospital cardiac arrests that don't respond to field treatment are probably not going to ultimately survive. So, you know, in years past, if we started resuscitation, then we obviously continue those resuscitative efforts to the hospital. It's a whole different way of thinking about those patients and treating those patients now. I get that we're still transporting a lot of those patients, but I think you will see in years to come that we will do more stopping resuscitation on the scene on patients who have not responded to scene treatments. So what about when do you stop those resuscitative efforts? I think from a BLS side, unwitnessed arrest, 3 periods of high quality CPR, 3 AED evaluations with no shock advised, and no return of spontaneous circulations. That's sort of a national standard of when you can stop resuscitative efforts and terminate those efforts on the scene. From an ALS side, obviously those same criteria, and then building on those, you've got an airway management, King Airway, ETQ, vascular access, and you've still got persistent PEA, persistent asystole, 20 to 30 minutes into the treatment, and a persistent end-tidal CO2 that's very low, which I want to talk about just a moment. And that if you have a persistent low end-tidal CO2, then that patient probably does not have a pulse. Some people are even advocating not stopping CPR during resuscitation and just basically watching the end-tidal CO2. If it's persistently low, and I say low, less than 20 basically, then they probably do not have a pulse. Once you see it spike up to 25, 30, 35, they've probably gotten a pulse back. So you may see more and more of that, basically looking at end-tidal CO2 values as determining if the patient has a pulse or not. Now, let me say this, that as far as termination of resuscitation that we just went over, hypothermia, drug overdoses are another animal. If they're hypothermic, drug overdose, then you probably need to transport those patients if you're continuing resuscitation. What about pediatric termination of resuscitation? Now that's another sort of a touchy situation as well. Most of the time, especially on SIDS deaths, we know that we're probably not going to resuscitate that child. However, many of us will advocate, and I'm certainly one that advocates transporting those patients to the hospital. We need to get them out of the house. For nothing more, we need to get the parents out of the house. We need to let the parents know that we tried everything that we could for that infant. So we sort of advocate in EMS that on a pediatric child, a pediatric patient, we really don't do a lot of termination of resuscitation on the scene. So what are our take-home points on this? One, contact medical control if you have any problems or any questions about whether to start resuscitative efforts. Termination of resuscitation on a pediatric patient, err on the side of transporting those patients. If you've got somebody that is in a blunt trauma patient, they're in cardiac arrest on the scene, probably not going to survive. Potentially could, but probably not. Penetrating torso injuries, contact medical control, they may want you to work those patients. And then remembering the BLS and ALS indications for termination of resuscitation. Thank you.